6:04. People can join in.
Okay.
Ready?
All right.
All right. Thanks everybody for joining us today. We have special guest, Dr. Carmen Castillo, who is a local dentist here in the South Bay in the Manhattan Beach area. And she's also a client of mine over at Osteostrong. So she wants to come in and strengthen her bones. And the reason why I have her on is to talk about dentistry and talk about osteoporosis and how it affects the teeth. And also she'll talk about dental hygiene and basically how to keep the teeth that you want to have for the rest of your life. So take it away.
All right. So I am Dr. Carmen Castillo. I am a private practitioner in Manhattan Beach, and I've been a dentist for about 30 years. I went to the University of Pacific in San Francisco. After dental school, I did a general practice residency at the University of Miami. And I'm currently on the board of directors for the Children's Dental Health Clinic in Long Beach, where we see lower socioeconomic kids and giving them fabulous dentistry. I learned about Osteostrong. I am a client of Brian's at Osteostrong, and I became interested. A patient of mine referred me to Osteostrong. I recently had a bone density test done. I have been osteopenic in past years, and the bone density said I was osteoporotic. So I said, oh my, I have to figure out what I'm going to do to stop the resorption of my bone. And I was looking for an alternative to the medications that are out there to stop the resorption. Probably one of the reasons I have osteoporosis is my mother is osteoporotic, and she's 97 years old. And I'm going to figure out what I'm going to do to keep the bones from resorbing. I know how you all must feel. You probably have eaten, you say to yourself, I've eaten well, healthy foods, I've drank milk my whole life, I've exercised, I've taken vitamins, and I'm still osteoporotic. What can I do? And how can I stop the resorption from continuing? So what I'm going to do tonight is I'm going to help answer any questions that you might have about the teeth, because no one wants to lose their teeth. So I'm going to ask Brian at the end of the of our presentation here tonight. I'm going to give a prize to the person with the most interesting question. And Brian is going to be the judge of who that person will be, who the winner will be. Okay, so here we go. There is a correlation between, let's see, how do I?
Press share again.
And is that at the, oh wait, it's down.
Bottom,
Let's see, no, that's at the very bottom.
You had it the first time.
Oh, I know. How did I? Let's see. Oh, here. And oh, here, share. Okay, here we go. Okay.
Perfect. Yep.
So there is a correlation of research studies have been done between osteoporosis and periodontal disease. Periodontal disease is not, osteoporosis does not cause periodontal disease. You're just at a higher risk of developing periodontal disease. Let's see. So how do I go to the next frame? So the research studies indicate that the correlation does exist. So in osteoporosis, the risk factors are older age, female gender, postmenopausal, Caucasian or Asian race, which I am. I'm half white and half Asian, a low body mass, cigarette use, a large intake of alcohol, inadequate calcium and vitamin D intake, physical inactivity, taking medications such as cortisone, prednisone, Valium, and gabapentin are some examples. By 2020, 1 in 2 Americans over the age of 50 is expected to have or to be at risk of developing osteoporosis of the hip. Even more will be at risk of developing osteoporosis at any site in the skeleton. So how does this all work? So osteoporosis is the resorption of bone. And so you have little bone, and then you have periodontal disease, which is an inflammatory response to bacterial infection. So if you have a tooth that's grossly decayed, the bacteria from that invades the tissues, causes poisons and toxins to form. The bone wants to get away from it, so it disintegrates. Once you've lost bone, you can't get it back. You can only stabilize it. So genetics, like for me, that plays a big role in it, but hormonal changes, the decrease in estrogens. So inflammation in the gums is a very big thing. And one of the things that we must do is stay very, very clean. By staying clean, we decrease the chance of the inflammation and therefore further loss of bone. So some of us are on medication. They're medications, these are the medications that have been suggested. The last 3 are injectables, and the 2 on the top are oral bisphosphonates. And one of the scares about these drugs is osteonecrosis of the jaw. And what that is the bone actually dissolves. So one of the reasons I wanted to find an alternative to stopping bone loss is because I wanted to avoid taking the medications. This is a picture of actual patient of mine who developed osteonecrosis of the jaw. It's a lady in her 80s. She had breast cancer. She was on a lot of medications. Prednisone was one of them. And she had periodontal disease. She wore a partial. We had recommended more frequent hygiene appointments so they could help control her periodontal disease, but she didn't want to follow that. She came in one day with very loose, I hadn't seen her for a while. She came in and she had some very loose teeth that were grossly decayed. I noticed some pus coming out of this area right here. And she was in pain. So she needed to have these teeth taken out. She was on Prolia injectables for a long period of time. So I referred her to an oral surgeon who removed the teeth, and this is what subsequently happened. This is exposure of the jaw, very painful. It can have lots of pus coming out. And so she's having to deal with this with long-term antibiotic use and debridement of the area. But the incidence of osteonecrosis is rare. And for injectables, the incidence is between 1 and 10% of patients using these medications. And for the oral bisphosphonates like Fosamax, It's 0.001 to 0.01%. That is very, very low, very rare. So you don't have to be afraid if you choose to also supplement with the Fosamax or oral bisphosphonates. So why is it important to have regular dental care? Many people see their dentist more than they'll see their doctor. And so we're able to help you figure out if you have some issues with your gums and your bone. We can also say you didn't know you had osteoporosis. We can tell from your x-rays and from clinical visualizing clinically whether you could be a potential osteoporotic patient. We can tell by loose teeth, there's gum recession. We do measure bone levels around the teeth. So it is important to have regular care. What happens when you come to a dental appointment to determine your periodontal status? There are 4 stages to periodontal disease, and one of them is gingivitis. Most people have gingivitis that is not periodontal disease. And then there are several stages of periodontal disease that are slight, moderate, and advanced. The way we figure out what your stage is we will measure the spaces around each tooth. We'll measure the top with a special ruler. We'll measure the top of the bone. This is bone here to the top of the gum. Research studies indicate that a measurement of 1, 2, or 3 is a space that your toothbrush and floss can get into to clean. If the space becomes larger, 4, 5, 6, or above, your toothbrush and floss cannot get into it. Professionally, I or my hygienist can get into a space that's up to 5, 6. And once it gets beyond 6, we can't handle it either. Then a periodontist needs to go in and reshape the gum tissue and the bone to decrease the pockets so that you can maintain it better and we can help you maintain it. If someone has a lot of 4, 5, 6s or above in measurements, we may recommend something called periodontal therapy, which is deep scaling. What we'll do is divide the mouth into 4 sections, 4 or 6 sections. We'll numb up each section, go down to the bottom of these pockets, clean everything out, decrease the inflammation, and put you on a closer recare. This is a picture of diseased gum tissue. Here you'll see inflammation, you'll see recession. If I were to probe or measure the pockets here, you'd see bleeding. When you see your gums bleed, it's a sign of active infection. You should, when you're brushing and flossing your teeth, you should not bleed. So if you are bleeding, you want to brush and floss that area even more. It's releasing the poisons that are in the gum tissue. Once you do that, then after several days, the bleeding will stop and the tissues will be a lot healthier. So this is healthy gum. The tissues are flat, the numbers are smaller, and it's more maintainable. Any questions so far about anything? All right. Here, this is the special ruler that's used. We know that the bone in your jaw is what holds the teeth in your jaw. So you need bone to hold your teeth in. When your teeth get loose, that's when the bone disintegrates around the tooth. So here's an 8mm pocket. We know that we can clean, you can clean up to a measurement of 3. I can clean your teeth up to 5, 6. And then there are 3mm that don't even get touched. So this is what it looks like on X-ray. All this white stuff here is bone. And then you'll see a gap, a dark gap from here to here. The gum tissue should be at the neckline here. So all this black area here is bone loss. And you'll look at how much root is in the bone, very little. So this tooth is loose, and eventually it'll probably fall out. Okay, how to prevent teeth from falling out. So here again, here's a picture of normal bone. Goes up to the necks of the teeth here, and it's in a horizontal architecture. Here in periodontal disease, you'll see a step of bone. You'll see this root here. It's has very little bone around it. It's probably very loose. And here you have, we call this a furcation bacteria. Very hard for you to clean this yourself. This is where bacteria will hide, and then bacteria hides, and then it causes inflammation, and the bone just keeps disintegrating. So what can we do? We can do what's called deep planing, which is root planing, or you'll hear deep scales. It's where so what happens when you have a lot of bacteria around and inflammation, the tissue detaches from your tooth. And when we clean it off, clean the tartar and the bacteria and get the poisons out, the tissue can reattach to the tooth. So we have to get below, we have to get down to the bottom of that pocket and clean everything out. Once that happens, then we have, we'd like to have shorter recares, which means having you come in every 3 to 4 months. Sometimes we have to have you come in every 2 months. It depends. We customize your hygiene for whatever situation you have. Okay, tissue grafts. You've heard about long in the teeth. Here you'll see that there's gum recession, so the gum should be right at the neck of the tooth, and here you'll see some root. We can actually graft tissue from your mouth or from a donor tissue and place that tissue here, and then you'll get nice, healthy gum here that will protect the bone. Pocket reduction surgery can be done also to reduce the pocket depths to allow us to be able to maintain it better. So here is inflamed tissue, very big pockets, probably bleeding. And with pocket reduction, we can recontour the bone, recontour the tissue, and then you have more access to being able to keep it clean. Bone grafting. We do have availability of bone grafts. So here you have a missing tooth, and say you want to put an implant in here. Well, when you remove a tooth, this bone right in here, this pink, collapses, and you can't put an implant where there is no bone. So we can put a bone graft in, and what happens is this bone actually fuses with your bone and beefs up your bone quite considerably to make it ready for an implant. So what can I do if I lose a tooth? Here, this young lady, she's lost some teeth. She has grossly decayed teeth in there. Her bone is resorbed quite a bit. You can see here where the teeth are, the bone is still a little bit hefty, but then in here, she's lost quite a bit of bone. Teeth actually hold the bone up. So when you lose a bone, tooth, the bones will collapse. So if you choose to do nothing, this is how you are before losing all your teeth. And this is what happens to you skeletally when you lose teeth. Because what happens when you lose teeth is your bite starts to collapse and everything, the bone keeps shrinking, and it just, you have no bone facial support any longer. There are some removable appliances that can be used for missing teeth, partials, and it's very easily maintained. You take it out and you can brush it very nicely. You have to brush the sides of these teeth to maintain them so that they support this partial removable appliance. Then there are bridges. So you have a missing tooth, and then you have two teeth on either side of the missing tooth. These teeth on either side of the missing area are prepared to receive crowns. The missing tooth is also a crown connected to the two side teeth. And then this is cemented in, and you treat it just like a regular tooth. It doesn't come out. It just has to be flossed a special way. Here you see it in live. There's a large filling here. There's some decay in here, the missing tooth. And here it is cemented in and fixed, so it doesn't come in and out. Then we have the implant. So very important, if a tooth is taken out, this is the tooth, the bone does collapse, so we put a bone graft in. We wait till it heals. Then a implant fixture is placed in the bony site. Healing occurs. Your bone actually fuses together and integrates with this implant. Then a dentist will create an abutment, which is a connector that connects this implant fixture to a crown. And then you can treat this just like a regular tooth. You never need a root canal again. You never need to have it extracted, and you become bionic, basically. We also have the benefits of removable. If you have severe periodontal disease and you lose all your teeth, a removable denture. It doesn't always fit well if you don't have a very high bony ridge here. So we have recently finessed implant fixed denture, where implants are placed in the bony ridge, and then the denture is screwed in to these implants. So that works very nicely for patients that want to have security and not have the denture moving around a lot. So also orthodontics, moving the teeth around into a better position, a better functional bite, closing up gaps. You can do conventional braces, or you can do, there's a lot of clear aligners that are out there. For instance, you've heard about Invisalign, and that will close gaps and put teeth in a better place for a healthier bite. Also, this is a patient of mine who didn't like having this black triangle in the front of her mouth. So she wanted it to be closed up. She actually ended up losing this tooth. So an implant had to be placed in this location. And then we had to do crowns and veneers, and this is how it all turned out. So there are a lot of things you can do if you have damaged teeth, and we are living in a great time because we have so many options of things that we can do, and dentistry is so great that people don't have to know that you've lost a tooth or that you have gum disease, as long as we use the great technology that we have out there. So I can turn this over to you. If you have questions, it usually answers, your questions will usually complete the things that you want to know about teeth. So I'm sure that you have questions. So go ahead and shoot.
Yeah, just go ahead and unmute if you want to ask a question. Thank you, Dr. Castillo.
I wanted to, first I was wondering why would she have that black? What caused it to be black between her teeth?
Oh, this?
The last picture, yeah.
This one? It's actually a space. So her teeth are really, really thin. She's lost a lot of gum tissue on these teeth. And that's actually, you're looking, her tongue is on the other side of this.
Yeah, and it's black too.
Actually, a space, you could almost put her tongue in there.
Yeah, just.
You can see her tongue going through it.
So what my question was, it sounds like if I were to go to you, you could, by looking at my teeth, you could tell how bad my osteoporosis was. And over the year, you could see whether it was getting worse or better, could you?
Yes, we could.
So that would go good with
you probably have records from your dentist that you went to, and you can compare from year to year, actually. And you could see if you have active, you can also determine if you have active infection. Like maybe you even know now when you brush and floss your teeth, do you have any bleeding?
No, but I had back a long time ago, well, not that long, but I had to go to a periodontist because I had I think I had a number 9 on this one tooth.
Oh, yes.
5 and another. And then we ended up doing implant in the number 9. Well, no, that was before. I did the implant before. And I didn't have enough bone to take bone to put in there. So we had to use that bone graft.
The bone graft. So the bone graft took.
Yeah, it took, but I couldn't use my own bone. But at any rate, then when I had the 9 and the 5, he's had me go to the orthodontist, and we got it cleared up really quickly, and I've been going to them ever since. As a matter of fact, I quit going to my dentist, and after that I was going every 3 months. I still go every 4 months, sometimes 6, but most of the time every 4 months. And I'm always like at 2s and 3s.
Absolutely.
Every once in a while, I have one that'll pop up to a 5, but we get rid of it right, because I use I brush all the time, and I use a water pick and floss and do everything. So I really
excellent. Well, so you know that once you're a periodontal patient, you're always prone to going backwards, like having an issue. So really important, what you're doing is excellent. You're staying as clean as possible because the bacteria is what's going to cause the inflammation and cause the problems. You can stabilize it, and that's what you're trying to do, is just to keep what you have and stabilize it and keep it that way.
Will that help with because I have osteoporosis in my left hip and my spine?
Excuse me, what?
I said, but I have osteoporosis.
Yes.
And so by doing this care for my dental, that helps along with the Osteostrong and everything, all the proper eating and everything that I'm doing, hopefully.
Yeah, I don't know. The exercises are not really going to put the bone back in your jaw. But your goal is to keep it from, it's to stabilize it and to make sure that the inflammation doesn't come back. And if it does, that you address it immediately. And that you also, when you have these longer teeth with the recession, you're also more prone to root caries. And what root caries is actually getting cavities at the gum line, and because it's very difficult to clean at the gum line.
I lost a tooth right on the upper thing, but he said that the bone and everything was good, so we didn't even have to replace it. Way back in the top upper right. Number what? I don't know the number.
So your number sounds shallow. have you had to have any tissue grafts?
Not since that other time when we did the implant. Well, actually, I have 2 implants. I have one here and
Yeah, well, like I said, we're living in such a great time because we have all these options, the implants and just being able to create gum tissue. Like if you look at this picture right down here, she had so much bone loss that we had to create a pink tissue to make it blend in. So that these teeth didn't look too long.
yeah.
So they looked more normal like the other teeth.
But when I was saying about by watching your teeth, I know it's not going to affect your spine, but if your teeth got worse, wouldn't that indicate that maybe your spine is losing bone too or something?
If your gums are lower, you mean if your bone is resorbing?
If your bone, yeah, if your bone is.
It could, if it's resorbing, it could be an indication of the rate of loss on your spine, but I don't know if there's a correlation between the spine and the jaw.
Probably not. Probably.
Yeah, so.
But that's
And like I said, osteoporosis doesn't necessarily cause periodontal disease. It just, you're at a higher risk of getting periodontal disease.
It's funny though, you say that you can't grow bone back in your mouth, but you can improve the bone in your skeleton by, by what all the things that we're trying to do, like with osteostrong.
Well, we are doing the bone grafts, and it's amazing some of the successes we've had with the bone grafts, but it's all on an individual basis, and it doesn't always take in everyone.
I wonder if you could use a bone graft in your spine.
That would be nice. And there's some people that develop more bone in their jaw from grinding and clenching. I wish that we could take that and take all of that and transplant it somewhere else. That would be good.
Yeah.
So,
about, I'm going to go back on C again. As far as, calcium, as far as calcium, don't you agree that the best way to get calcium is through your food, through your diet, and not by taking calcium?
I don't know. I don't know if you can get enough from your diet.
I think
like I said, my whole life have drank milk with calcium in it, and here I am. So, but my thing is genetics. Definitely. Did your mother or father have osteoporosis? Do you know?
No, I know they didn't. My mother didn't live long enough to get it.
Yeah, so
I'm sure my dad probably never had his bones measured.
Yeah, so that's
we live so much longer now that
absolutely.
I'm sure my grandmother probably had it because she had the back thing, and she lived to be 85, so I'm sure she had it.
Mona, let's move on so we can get some other people asking questions. Thank you. All right, Sarah.
I thank you so much for doing this presentation. I was wondering about your patient who had the necrosis of the jaw and was on Prolia. I believe you said that she was a cancer patient and
Yes.
on Prolia for an extended period of time. Do you happen to recall how long she was on that?
On the Prolia?
Yeah, that was recommended by my doctor, and I understand that necrosis of the jaw is more of an issue for cancer patients because they have a more intense.
Yes, and remember, she was also on prednisone too. She was on high doses of prednisone, and I think it was more because Prolia, you're supposed to be on it for 3 years, and then they have to take you off, right?
My doctor was saying 2 years and then 2 years on Fosamax to stabilize.
She was way over that.
Mhm. Okay.
And she was very immunocompromised, and her hygiene was atrocious. I mean, it was just, she wouldn't let us do the deep scales. We suggested she come in every 3 months to allow us to help her, keep it under control. We couldn't monitor it with x-rays either, so we couldn't really, we would just guess we could see that loose teeth were coming out. So she was prone to that because she had predisposed herself
Right.
to the infection. So like if you did Prolia and you kept yourself very, very clean, you didn't have decay, didn't have to have a tooth extracted, I don't really see, I don't think it would be a problem. And, the Fosamax, it's just very rare. And you have to be deliberate about that inflammation that you could cause with the bacteria. So keeping your mouth as clean as possible is just the key.
Yeah. I'm also curious, this is probably a question for my own doctor, but once you have, you've been on medication and you are more inclined towards that, I would imagine that it's more of a challenge with a more difficult extraction. I'm one of the few people who has all my wisdom teeth, but I also have crowns and fillings in all of my wisdom teeth. So
You have crowns and fillings on your wisdom teeth. So it sounds like you have space for your wisdom teeth. Right?
got a big
So you're not thinking of taking them out and they don't have recurrent decay on them. Just want to make sure you don't get decay, because the decay could lead to infection there.
right.
And if you were going to have an extraction, they would take you off the medication before they did it for a period of time.
So what I was
Prolia, you're taking every 6 months.
Yeah.
6 months.
Right. What I was hearing from my doctor was that you would go on Prolia, or I would go on Prolia for 2 years, and then Fosamax for 2 years. And then after that, are you more able, because longevity is in my family. So I'm like thinking about what it's going to be like in my 90s.
Right. So your parents are in their late 90s or 90s?
My dad made it to 95. My mom had breast cancer and did not make it that long, but so.
Yeah, so I have the same thing. And I'm having looking at statistics and speaking to endocrinologists, I'm considering the Fosamax.
Right.
But I haven't done it yet.
Yeah.
I'm trying to just do alternative things right now, but I'm kind of leaning to Fosamax.
Right. Thank you. I appreciate it.
Yeah.
Yeah, it was interesting in your study. You said the injectables versus bisphosphonates. The injectables were almost like 100 times worse on the statistics for necrosis.
But injectables are used for metastatic issues, so that's the other, where is that?
So you maybe typically would have more cancer.
So yeah, for the the injectables are used for management of bone metastasis. So yeah. So, but it's still, that's pretty low. It's still low. Not as low as the oral bisphosphonates, but it's still low. Yeah. And if you just keep yourself, like I said, clean and try to make sure you don't get decay, I think you'll be okay. Because it does look ugly, doesn't it? Yeah.
Yeah, that's.
Yeah, you don't want that to happen. It's very disfiguring if it I mean, it can be worse than this. And she's okay. She actually has a removable appliance that we're using. And the reason she would not come in is because she knew the teeth were moving. And the teeth was a support for her removable partial.
So was her jaw able to heal eventually after that?
Well, she's still recovering from this.
How long after?
It's been months. It's probably been 3 months, but at least the bad teeth. And so we got to keep, so the teeth that are remaining, we have to keep these really clean. As you can see, the bone is all resorbed here. There's no teeth to hold the bone up.
Right.
But this has to be stopped completely, and it's a lot of work with antibiotics and debridement constantly.
Thanks.
Yeah.
Great, thank you. Martha, do you have any questions?
Yes, hi, I have a couple of questions. One for Dr. Castillo and one for you, Brian. So Dr. Castillo, how do we know if we might have an allergic reaction to a bone graft? And what percentage of the
A bone drug?
patients have a reaction? Yeah, bone graft?
Graft.
Oh, bone graft.
Oh, graft, yes.
Oh, like when you have a bone graft. You mean having rejecting the bone graft? Is that
Right, how do we do, is it possible to find out before or until it's implanted?
Oh, the bone, to see if you're going to have a reaction to it?
Correct.
And you're meaning a reaction to, like, are you allergic to it? Are you going to have
Right.
swelling?
Yeah, if your body is gonna accept it or reject it.
It will fuse together as long as you keep the area clean and don't traumatize it. And you don't really know until it's fully healed how much of it's going to take. The worst that can happen is that you you'll need more bone graft. And it may not beef up. Like sometimes you have to do a bone graft a couple times. So you'll add bone, it'll grow, and then you'll need to do it again.
So there's no test to find out before.
No, it's just kind of like doing it and then seeing how the body responds to it. And if you need to augment it a little bit, then you add more, you'll do another bone graft.
What percentage of the patients that you've seen have a bad reaction?
To bone grafting?
Right.
I don't see bad reaction. It doesn't like I said, it doesn't always take the first time. Like there may be a little bit of density created, and sometimes I wouldn't say, I'd say maybe 20% might need to have a second bone graft placed in there. Meaning, so imagine you're filling this area here, and your bone needs to fuse together with what's placed in there. And maybe it doesn't take all, and it just all depends. I mean, everybody's different, what's going to take and what's not. And maybe it fuses like in this area here, and this may not have fused together as much. So then you pack in more bone graft to beef it up a little bit more. And it, would probably take, because one of the things too is your old tooth that was in here depends on the infection. If there was a big infection in here, you can't put in bone graft in a place has poison in it, right? So you have to let the infection sometimes you need to have the infection cleaned out first for a while before you put the bone graft in.
Okay.
So it depends on the person's toxicity in the area, how badly abscessed that tooth was at the time of extraction. So
Okay.
I hope that answers it.
Yes, thank you. Brian, would you know how, if the sessions at Osteostrong, if you know if they can be paid through a health, a flexible health spending account?
Yeah, so yeah, we do accept FSAs, so flexible savings accounts, or HSAs. So you can use that.
Okay, thank you.
All right.
And thank you for setting up this webinar.
Welcome, welcome. Good. Hope to see you in there, Martha. Barbara, any question? No? Or Laura, any questions for Dr. Castillo? This is perfect time, Q&A, you have her attention. Going once, going twice? No? No? Oh, there we go. Oh,
No,
there's Laura.
thank you. I'm here, but I'm just listening. I don't really have a question. Thank you.
Okay, good, good. So you have healthy teeth then, Laura?
Let's hope so.
It's a lot of work, isn't it, your teeth? It's amazing how much you have to do each night and each morning, but it's worth it.
Yeah,
Mhm.
my dentist said only floss the teeth you want to keep.
And what gives you greatest pleasure in when you retire, right? Your teeth.
Your teeth.
Eating.
Teeth.
So, okay, Brian, well, who do you think had the most interesting question?
Interesting question. Let's see. The bone graft one was pretty interesting, I thought. So Martha, do you have bone issues in the teeth?
No, I mean, I have gum issues. Thankfully, actually, I have all my teeth, and every time I go to the dentist, they want to recommend that I take out my wisdom teeth out. So, but no, thank goodness I have all my teeth, but I have issues with the gum disease. So I'm working on getting that cleared up.
All right, I think Martha's the winner. Dr.
Okay,
Castillo.
yay.
Yay!
Well, Martha,
Thanks.
I am going to give Brian this, and he can give it to you when you go to Osteostrong, okay?
Thank you very much. Thank you.
Yes. Some little dental goodies.
What is it? It's like bags of candy in there?
Thank you.
It almost looks like candy, but it's not.
Can you hear me?
Yeah, Barbara, go ahead.
Yes, thank you. I'm sorry, I just taken a while to get the hang of this. I have a question about osteoporosis medications. It was recommended to me that I take Prolia, and they said it can cause dental problems, but they tried to minimize it, but my doctor has to sign a release form, and it sounds pretty scary. And so I'm kind of looking around for natural medication instead of these drugs that have side effects. And I wondered if you've come across patients that have that dental problems from taking osteoporosis drugs to prevent osteoporosis,
Yes.
like Fosamax, Prolia, and there are 4 or 5 of them. And I just wondered how often that happens.
So these are the medications. Can you see this?
No, I can't see. All I can see is a list of names.
Okay, so
But I'm hearing you fine though.
okay, so you're right. There's 3 injectables, and there's 2 oral
Mm-hmm.
bisphosphonates. Fosamax is one of them. But the one thing, and this might alleviate, the incidence of osteonecrosis in the injectables, these injectables are used for metastatic disease, is between 1 and 10%,
Okay.
which isn't very large. And the oral bisphosphonates, the incidence is 0.001 to 0.01%, which is, very, very, very tiny.
So, and you know, the
Rare.
Prolia was recommended because it's only twice a year, and the Fosamax you have to do like every Saturday, and so, but it sounds like the Fosamax, it's the oldest one, but it would be the best one, dentally speaking. Is that correct?
That's what I would think. So one of the side effects of Fosamax too is gastritis. Like if you have gastric reflux, it might be an issue for you. I don't know.
No, I haven't heard of that, and it's not an issue for me.
Yes, then maybe you want to go that way, or
yeah, it sounds like it would be safer, because if, to be on Prolia or to get problems like, with the dental problems and be free of osteoporosis, it's like you'd be nice and strong, but a pretty ugly smile. You can't have any teeth in your mouth.
Well, just remember that these medications, they don't really put back the bone. They just stop the resorption of the bone. So they just stop these cells that eat up the bone.
So what I heard was that it makes that it starts getting loose. The jawbone gets kind of squishy, and it doesn't hold the teeth very well.
That's right. Periodontal, you're at higher risk to periodontal disease. And the periodontal disease is actually an inflammatory response to bacterial infection. So it's very important that you stay clean. And if you do have pockets that are 4 and above, that you try to do like deep scales or the other, there's tissue grafts, there's deep scales, there's pocket reduction, to get the pockets to a point where you can clean them. You can your toothbrush and floss can only clean up to a measurement of 3, 1, 2, or 3, and anything 4 and above you cannot get. So your hygienist can get up to 5, 6. Once it gets beyond 6, then your periodontist has to go in there and do some procedures to reduce the pockets so that you can maintain it, or I can maintain it. And you want to be on a closer recare, meaning going in every 3 months or 4 months to keep it under control. Bacteria makes their greatest destruction every 12 weeks. So if we remove the biofilm that the bacteria are in more often, then they can't do their destruction and cause the inflammation and potential bone loss.
Well, that's good news to me, because I do go every 3 months, and I've taken care of my teeth, just very well over the years. And whenever I have pockets, I have it, I get the little surgery to cut it back,
or the deep scales. Yes.
Yeah. So
really,
it's just that I'm at the point where this medication is recommended. So if it's Prolia's 10%, I think Fosamax, because I am concerned about my dental, condition. And so Fosamax, I don't know what the drawbacks are to that, except that it's something that you just get tired of doing, but you have to do that every week.
Well, don't you take vitamins?
I'm sorry?
Don't you take vitamins?
I do.
So it's like another vitamin in a way.
It is. Yeah, it is.
So it's just another one. And it's only once a week. You only have to remember it once a week. And if you don't do it on exactly that week, at the 7-day mark, so you take it on the 8th day, or you take it on the 10th day.
Well, I know you can't lay down, right? You can't take it. You can't lay down for half an hour, but
for 30 minutes. And you take it on an empty stomach.
Yeah.
And that's because of the gastritis that could possibly occur.
And then do they, just one quick more question. Do they recommend that you take a break like every 3 years? Or do they take you off of it permanently, or can you take it the rest of your life, or what is the status with that?
I think it's every 3 years you take a break, some kind, but I don't know.
Have you heard of a medication called Algical? Or it's for osteoporosis?
Algical.
Yeah, Algical, it's a form of calcium from algae, from kelp.
Oh,
Yeah, it's pretty bioavailable. But the thing you have to recognize is that even if you take calcium, think of it, my analogy is like you have bricks and you have cement. To build a wall, you need the bricks, so basically calcium, and then vitamin D and K to create the catalyst to then create bone. So just because you take Algical doesn't mean you're going to create bone. So you have to have the vitamin D, vitamin K, and also your brain has to kick in osteoblast to say build bone. So it's just a building block.
I see.
Yeah.
I see. I had a friend that had a test after 6 months, and she had built more bone.
with Algical?
With Algical, and she's really, high on that. So I'm trying to make a decision here which route to go. I don't think I can do them both. I don't think it's a good idea to do. Would it be Fosamax plus Algical?
But Algical is like a vitamin calcium, right? And so you still need to take calcium even though you're taking Fosamax. So it wouldn't matter if you took both of them.
Oh, okay. I like that. That's easy.
Question
Well,
for
thank you. Thank you so much. You've really, really helped me.
Perfect,
I'm so glad I tuned in. Thank you.
perfect.
I have a question for you guys on Algical. Is there any concern about contamination since it's coming from the ocean?
So I don't know. I don't know if they do any kind of certificate of authenticity with any kind of batch testing. That's something you'll have to go onto their site and take a look. So I don't know.
What is it called? A certification of what?
Certificate of authentication.
Okay.
So basically they're doing a lab test to say, here are all the chemicals inside of this batch.
Thank you.
And it's best to get on a batch, every batch that they make, versus just like a one time, like, oh, they only do tests once a year. That doesn't help.
Okay.
Okay.
Thank you.
Yeah, you also take strontium with that program too,
Mhm.
which is another mineral.
Great. Any other questions before we wrap up? No?
No, thank you so much.
I just think the concept of a bone graft in your spine sounds like a pretty good
I
concept.
think we should invent that. We'll make
Yeah.
They could give you a shot
a
of
new product.
graft in here.
All right, Mona, you're going to be our patient, right? Our guinea pig?
Oh yeah, right.
That would be awesome.
Gotta sign up. Dr. Castillo is going to be injecting you.
I need it.
Thank you so much.
All right. Well,
Yeah.
and
Thank
everybody,
you.
yeah, if you want to talk to Dr. Castillo, she's in Manhattan Beach. You can find her. She's just on Manhattan Beach Boulevard. So give her a call or
My
stop
last slide. Happy flossing, okay?
Okay. Thank you.
by. Thank you, everybody.
You're very welcome.
Bye.
All right. Bye.
All right. Okay.